Hi, my name is Dr. Julia McNabb Baltar. I am the co-director of the Center for Pancreatic Disease at the Brigham and Women's Hospital, and today I will be talking about acute pancreatitis. I have no disclosure. So first, the outline. I will talk about what is the typical presentation of acute pancreatitis, how do you actually make the diagnosis, how do you identify the etiology of acute pancreatitis. We will go over the severity, treatment, and some complications associated with acute pancreatitis. So first, to make the diagnosis of acute pancreatitis, you need 2 out of the 3 following criteria. The presence of abdominal pain that is consistent with the disease, and I'm going to go over this in one slide. The presence of an elevated serum amylase and/or lipase greater than 3 times the upper limit of normal. And if you're missing one of them, then you need characteristic findings on abdominal imaging. And this is based on the more recent ACG guidelines on management of acute pancreatitis. So what do we mean by clinical presentation typical of acute pancreatitis? We see a patient presenting usually with epigastric or left upper quadrant pain. The pain tends to be constant and may be increasing in severity. The pain may radiate to the back, chest, or flank. It's usually a severe pain, so most patients describe a pain that's 7, 8 on 10 at least. And something that would make you think is less consistent with the diagnosis if the patient has a dull, colicky pain located in the lower quadrant, a pain that fluctuates. You would need to make sure that this is not something else going on instead of acute pancreatitis. We used to think that hyperlipidemia greater than 3 times the upper limit of normal was very specific for acute pancreatitis, but now we're starting to see that it's maybe not as good as we thought it was. This is a study that looked at patients admitted in the ICU with an elevated lipase greater than 3 times the upper limit of normal. And they included 417 patients, and of those, only 159 were actually diagnosed with acute pancreatitis, giving the lipase a positive predictive value of only 38.1%. Interestingly, the median lipase level was different in patients with acute pancreatitis compared to patients that did not have acute pancreatitis. And they had other things including bowel ischemia, bowel obstruction, amongst other diagnoses. And the median lipase level was up to 1,164 in patients with acute pancreatitis, whereas it was only 284 in patients without acute pancreatitis. Of note, the lipase level used here had a normal cutoff of 60. So based on this, they estimated that the optimal cutoff value of lipase to help with the diagnosis of acute pancreatitis should be a bit higher, and they proposed 532 units per liter instead of the 3-time upper limit of normal cutoff that was previously suggested. And with this, they estimated a sensitivity of 77%, specificity of 78, negative predictive value of 85, and positive predictive value of 67. So this is interesting and something to consider when you look at patients that have elevated lipase. And now when we talk about abdominal imaging, so we know that CT scans are very helpful in terms of having good sensitivity, specificity up to 90%. But the routine use of CT is unwarranted and unneeded. So if your patient has typical presentation and elevated lipase, you may establish your diagnosis of acute pancreatitis that way and not get your patients a CT scan. Also, a CT scan and MRI also that are done within 48 to 72 hours may fail to show evidence of necrosis and may falsely reassure you on the clinical evolution of your patient. So it's not a good idea to do a CT scan or an MRI when you know the diagnosis of acute pancreatitis to estimate severity initially. It's not helpful. And this is a guideline recommendation that is strong, but based on low quality of evidence, unfortunately. When I would recommend to do imaging, such as CT or MRI, is if you are unsure about the diagnosis or if your patient failed to improve within the first 48 to 72 hours. And in that case, past the first 2 to 3 days, the purpose of those imaging will be to assess for local complications. Also, an MRCP may be helpful to detect presence of common bile duct stones as well as evaluate for pancreatic duct disruption. So this is a caveat when you would potentially want to do MRI imaging, but not to assess for severity. The imaging that you should do on your patient is an abdominal ultrasound to assess for presence of gallstone pancreatitis. This is again a strong recommendation based unfortunately again on low quality of evidence. So the first imaging you should do in those patients should be ultrasound. Now that you've established your diagnosis, you have to go and think of what is the possible cause of the pancreatitis. So common causes include gallstone and alcohol, but this also lists other causes, including rare causes such as autoimmune disease of pancreatitis. I'm going to go over this in a little more details. So we see that gallstone represents about 40 to 70% of the etiology of acute pancreatitis, followed closely by alcohol. And hypertriglyceridemia is also up there, 1 to 4%. And so in patients that do not have any history of gallstones or alcohol intake, you should obtain a triglyceride level. And a triglyceride level above 1,000 will be something that may cause acute pancreatitis. Lower levels are usually not causing acute pancreatitis, so if it's just a mild elevation, I would not attribute the acute pancreatitis to hypertriglyceridemia. You also have to consider the presence of a main pancreatic duct obstruction, and up to 5 to 14% of pancreatico-biliary tumors present with idiopathic acute pancreatitis. You also want to make sure you're considering the presence of an adenocarcinoma, especially in patients that are older than 40 years old. Other etiology includes medication. The 6-MP and azathioprine are very frequent cause of acute pancreatitis, very well established, and you also think of heart therapy as potentially causing the disease. Some infections also. Anatomical abnormalities can occur in up to 10 to 15% of cases, and then you would think of potentially pancreas divisum and sphincter of Oddi dysfunction. I would be careful attributing the sphincter of Oddi dysfunction at pancreatitis and make sure that the patient is referred to a center specialized in pancreas disease to make that diagnosis. Hypercalcemia also can play a role. Genetic syndrome, and this is something we would consider, especially in patients with family history of pancreatitis or in young patients presenting younger than 30 years old. And it's important to test early because you can have an impact on their long-term history. And some mutation includes PRSS1 mutation, which is the mutation seen in hereditary pancreatitis, CFTR that we see in cystic fibrosis, and SPINK1 also. Finally, we say idiopathic pancreatitis when there's no etiology established after investigation, including blood count and imaging. Once you've assessed the etiology of your pancreatitis, the next step is to evaluate what is the severity of the presentation. And fortunately, the majority of patients with acute pancreatitis will have a mild course, and this is up to 75 to 80% of patients. When that's the case, they have a self-limiting course, they have a brief hospitalization, they do not have any organ failure, and they do not develop any pancreatic necrosis. And they improve significantly, substantially by 48 hours. Have to be careful though, because some patients, most patients with severe acute pancreatitis will initially present as mild cases. So you have to follow your patient closely and make sure they evolve the way you want them to. We consider moderately severe acute pancreatitis based on the revision of the Atlanta classification as the presence of local or systemic complication without the presence of persistent organ failure, which is defined as organ failure lasting more than 48 hours. So a patient that can have necrotizing pancreatitis may have also acute peripancreatic fluid collection. So this is acute fluid collection around the pancreas, and also acute necrotic collection involving the pancreas or the peripancreatic tissue, but without the presence of persistent organ failure, or if they have just transient organ failure lasting less than 2 days without local complication, will be considered moderately severe. And they have an evolution that's a little worse than acute pancreatitis, than mild acute pancreatitis, but better than severe. And finally, the revised Atlanta classification defines severe acute pancreatitis as the presence of persistent organ failure lasting more than 48 hours. And you see here we're not including the presence of local complication or not in this diagnosis of severe acute pancreatitis. And patients with single organ failure do better than others with multi-organ failure. So how do we assess this? So we can use a different risk stratification tool. Serial bedside evaluation are helpful, where you measure vital signs, look at orthostatic vital signs of fluid overload, ARDS. The Ranson score above 3 can also be used. Problem with that is it takes 2 days to be able to establish this, so not as useful at the time of the initial presentation. Can also use Apache 2 score, and you're going to be at a higher risk, more severe risk if the score is greater than 8. You can use the CRP, but again, this becomes more accurate at 48 to 72 hours, and this is when the CRP is greater than 150. And remember that the initial CT scan or MRI is not going to be as reliable to determine the severity such as necrosis finding in the first 1, 2, but even 3 days. Another risk stratification tool that was developed at the Brigham is the Bedside Index for Severity in Acute Pancreatitis, BSAP. And this includes those 5 criteria. And each criteria, the more you have, the greater the mortality associated with the case. So BUN elevation, abnormal mental status, evidence of SIRS, patient older than 60, and presence of pleural effusion. And you can see here that most patients have low BSAP score, but the more you increase it, the greater the mortality. So once you've done your risk stratification, what do you need to do? So your initial assessment is, first of all, you need to be very aggressive with hydration. And as you know, there's no good treatment yet for acute pancreatitis. No medication has been proven effective to help treat the inflammation of acute pancreatitis. And so what you need to do is support your patient the best you can. So aggressive hydration as high as 250 to 500 cc per hour of isotonic crystalline solution should be provided to all patients except if they have cardiovascular renal comorbidity. And it's very important to be aggressive very early on, and they have the most benefit in the first 12 to 24 hours, and probably little benefit and potentially even significant harm if hydration continues beyond this first 12 to 24 hours. What solution should be used? We think that probably lactated ringer is a preferred isotonic crystalline solution, and this is based on a small randomized trial that was done where lactated ringer was administered versus saline, and this led to decreased level in CRP and SIRS, but it did not lead to improved mortality, unfortunately. But still, based on this, it seems that lactated ringer is a better crystalline replacement fluid. You should assess your fluid replacement very regularly, at least every 6 hours for the next 1 to 2 days, and your goal will be to see the BUN decrease. And you can also monitor your hematocrit, your creatinine, make sure that you're going in the right direction. If the patient becomes more hemoconcentrated, despite dehydration, you may need to increase it. You need to stay on target, because this is really how you assess how well you're doing with your hydration. You also want to make sure you're monitoring the urine output, the orthostatic vital signs. You want to maintain a good urine output. You supplement oxygen, and of course, you want to consider a good analgesia with parenteral narcotics because acute pancreatitis is very, very painful. Now if we change gear and talk a bit more about nutrition. So nutrition in acute pancreatitis has been an evolving field. In patients that have mild acute pancreatitis, you can start oral feeding immediately if there's no nausea, vomiting, and once the abdominal pain is either resolved or much improved. And what you should start is either a liquid diet or low-fat solid diet. They both appear to be as safe. So you can start those. And in terms of severe acute pancreatitis, it's better to use enteral nutrition than parenteral nutrition. So always use the gut whenever you can. And it's been reported to help prevent infectious complications. You will reserve parenteral nutrition for patients that are not able to tolerate enteral feeding, in whom enteral feeding is not available, or in patients that are not meeting their caloric requirements. And then what is the preferred route of enteral feeding? It seems that both nasogastric or nasojejunal are as safe and effective, but there's no good studies really comparing the two. So this is something of a field that will need to continue to evolve. There's been a recent trial, it's called Python trial, where early enteral feeding was assessed versus on-demand oral feeding. This was a multi-center randomized control superiority trial looking at early enteral feeding versus or initiation of oral diet at 72 hours. And this included patients with predicted severe acute pancreatitis, so people with Apache-2 score greater than 8 and often even greater than 14. And their outcome was a composite outcome of major infection or death at 6 months. And their results were very interesting. So they included 208 patients, and we see that 30% of enteral feeding versus 27% of patients with on-demand feeding had the composite outcome. Based on this, their enteral feeding is not recommended compared to oral diet at 72 hours. So this is something that's been very interesting and changing a bit the field. And you can see that the mortality was not significantly different also in the enteral nutrition versus oral feeding group. Now if we change gear, when do we want to use ERCP in patients with acute pancreatitis? So the use of ERCP will be reserved for patients with acute pancreatitis and concomitant cholangitis, and we recommend to undergo ERCP within 24 hours of admission in that group. In patients that have gallstone pancreatitis but do not have any evidence, either clinical or laboratory, of ongoing biliary obstruction, ERCP is not recommended. And what would be more recommended is to consider non-invasive use of assessment in patients that do not have evidence of cholangitis and or jaundice. And in that case, we recommend using MRCP or EUS to screen for the presence of common bile duct stone when they're highly suspected. Now if we change gear and we look at the role of antibiotics, they should be given for patients with extra pancreatic infections such as cholangitis. But this is something that has changed. Routine use of prophylactic antibiotics, even in patients that have necrotizing pancreatitis, is not recommended. They're recommended in patients with infected necrosis. And infected necrosis should be a diagnosis considered in patients that either deteriorate or fail to improve after 7 to 10 days. So infected necrosis takes time to arrive. It's not something that forms right away, because your patient initially may have significant inflammatory response and may have fevers in the first few days, but those fevers were more likely to be attributed to the inflammatory process and not to an infectious complication then. When you consider infected necrosis as a possible diagnosis is usually later, usually more 7 to 10 days later. And if you're not sure, you could do a fine needle aspiration, CT guided, to aspirate the fluid and send it for a gram stain and culture to be able to tailor your antibiotic therapy. Another thing that will make it suspicious of an infected necrosis is if you start to see the presence of air bubble within the necrosis of the pancreas. This is suggestive of infected necrosis. And so once you have established that you think your patient has infected necrosis, the antibiotic you should use should be an antibiotic that is known to penetrate the pancreatic necrosis. So example of that includes carbapenem, quinolone, and metronidazole. And those antibiotic has actually been proven to be useful in delaying or even avoiding the need for further intervention in those patients. And the routine administration of antifungal is not recommended as well. Now, when do we consider surgery for patients with pancreatitis? So in patients with mild acute pancreatitis and gallstone, they should have a cholecystectomy, and the recommendation from the American College of Gastro was to perform the cholecystectomy before discharge to prevent recurrent acute pancreatitis. Patients with necrotizing gallstone pancreatitis, they should also have a cholecystectomy, but this is usually deferred until the acute inflammation subsides and the fluid collection stabilizes or resolves. So this can be done later, once they've stabilized. Surgery is not recommended for patients with asymptomatic pseudocyst or asymptomatic pancreatic or extrapancreatic necrosis. And this is regardless of the size, location, and extension. So this is, again, something that has changed recently. Now, what do you do for patients with infected necrosis that fail to respond to antibiotics? So there was a randomized prospective trial that was done looking at primary open necrosectomy versus a step-up approach. Including percutaneous or endoscopic drainage, followed by minimally invasive retroperitoneal necrosectomy if they did not improve after the initial step. And interestingly, they found advantages of step-up approach. So of the patients that were randomized to the step-up approach, 35% did not require retroperitoneal necrosectomy. They also had less new onset multi-organ failure, less diabetes, and they needed less pancreatic enzyme. And overall, those interventions were less costly. It did not improve mortality, though. But based on this, the step-up approach has been a preferred open versus primary open necrosectomy. All right, so if we go over the take-home points that I want you to remember is in acute pancreatitis, you need 2 out of 3 criteria for diagnosis. And this includes typical abdominal pain presentation, lipase elevation greater than 3 times the upper limit of normal, and potentially even greater than 532 when your normal is 60. And if you don't meet the diagnosis with this, then you can consider doing a CT scan to make the diagnosis. Initially, you should always perform an abdominal ultrasound to assess for the presence of gallstone. Remember that you should wait after the first at least 2 to 3 days to obtain a CT scan because necrosis can take longer to appear, and you may underestimate that presence of necrosis if it's done earlier on. And remember that you always need to use a risk stratification tool, and we've talked about a few ones that are available, and should always favor enteral routes. So now if I go through the board questions. Question 1, a 35-year-old patient is admitted with severe epigastric pain for 10 hours associated with nausea and vomiting. At presentation, there are no signs of organ failure. Labs show amylase and lipase level of 390 and 590 units per liter with a normal of 160. The patient has a white blood cell count of 16, a lactate of 2.5. Why will you order a CT scan at admission? A, to confirm the diagnosis of acute pancreatitis. B, to assess for pancreatic necrosis. C, to exclude a surgical condition. D, to assess for severity of acute pancreatitis. And the answer is C, to exclude a surgical condition. And again, I want to stress that early CT or MRI may underestimate the presence of necrosis, and the only reason to perform it is if the diagnosis is unclear or to exclude other surgical disease or conditions. Question 2. What is the best fluid type to use for resuscitation in acute pancreatitis? A, lactated ringer. B, normal saline. C, D5. D, D5 half NS. Answer is A, lactated ringer. There's a randomized trial by Dr. Wu that suggests some improvement in SIRS and CRP level with lactated ringer. And based on this, it seems that this is a preferred mean of resuscitation. Question 3. You are caring for a patient with acute necrotizing pancreatitis who is developing worsening sepsis and organ failure despite maximal intensive care and broad-spectrum antibiotic administration 12 days after the onset of pancreatitis. You obtain a percutaneous CT-guided aspiration of the pancreatic necrosis that demonstrates bacterial infection. The optimal intervention at this time is A, continued antibiotic administration and supportive therapy only. B, percutaneous drainage. C, endoscopic transluminal drainage. Or D, surgical retroperitoneal debridement. And the answer is B, percutaneous draining. So your patient is not responding to antibiotics and needs additional drainage. It's too early to perform an endoscopic necrosectomy. Usually you need to have a nice wall that forms around the necrosis, and this takes usually up to a month to form. And so at this time, since we're just 12 days in, a percutaneous drainage will be what will help us temporize things and potentially avoid using or needing further endoscopic or a retroperitoneal debridement.